An oropharyngeal airway, or an OPA, is indicated for use in a patient who has a GCS score of less than 8 or a scoring less than 2 on the verbal scale. They come in different sizes, of a 000 up to a size 4, and it's measured from the level of the incisors to the angle of the mandible. To insert, the patient needs to be in the supine position, and you perform a head tilt chin lift. It's inserted into the mouth upside down. You then turn it 180 degrees to the curve of the roof of the oropharynx, avoiding the tongue. It's inserted upside down initially to avoid pushing the tongue posteriorly. You then need to check that your patient accepts the OPA, so it hasn't induced a gag reflex and they are not clenching their teeth. The complications of an OPA are that it can induce vomiting if it's too large, it can cause damage to the oropharynx, and it can push the tongue posteriorly if it's too small, which will worsen an airway. A nasopharyngeal airway, or an NPA, is indicated for use in patients requiring airway management, and also if an OPA is contraindicated or unable to be used. The benefits of an NPA is that it can be used in patients with a high GCS, it has less chance of inducing the gag reflex, and it can also be used in trismus, which is where spasm of the jaw muscles causes lock-in of the mouth. An NPA does not definitively manage an airway. So there's different sizes going from a 6.5, 7.5 up to an 8.5. It's measured from the nostril to the angle of the mandible. You need to lubricate your NPA in order to insert it. So it's inserted into the largest nostril at 90 degrees to the patient's face. If resistance is felt, you can rotate it 180 degrees or remove it and try again with the other nostril. You insert it until the flange reaches the nostril. NPAs are contraindicated if your patient has a suspected basal skull fracture, and the complications of them are nasal polyps and bleeding. Suction is indicated for use when there are foreign bodies or fluid in the oropharynx in patients with a decreased GCS or who are unable to maintain their own airway. To test the suction, I turn it on to full force, kink the tube, and ensure it goes above 350 millimeters of mercury. I then will test it on my gloved hand. If it's not working, I would check for leaks and blockages. To suction, a patient needs to be in the lateral position, which therefore removes the bulk of any foreign bodies and fluids. I insert the rigid catheter into the mouth, going only as far as I can see. I then place my finger over the hole, rotate in circular motions whilst on the way out. I only suction on the way out, and it takes less than 10 seconds. A rigid catheter can only be used when stationary. The complications involved with suctioning is that it can induce vomiting, induce bradycardia, cause aspiration, and when a patient is hypoxic, has soft tissue damage, or has laryngospasm. An oxygen bottle is identified by its 3 ports on the pillar valve. It will be labelled as oxygen and will be in a full white bottle if it's new, or otherwise in a black and white bottle. Oxygen use is indicated in patients who have a decreased GCS, are in respiratory distress, are suffering from shock, have a traumatic brain injury, are suffering from gas inhalation, have SAPs of under 94%, or when your judgment has deemed it clinically appropriate. On the regulator, you need to check the Bodox seal, and we need to check that it is there and intact. You attach the regulator onto the oxygen bottle, ensuring that the ports of the regulator are going to fit correctly around the right way. You tighten that up using a quarter turn to ensure that it is tight. Turn the oxygen bottle on, and you can see that this bottle is full. You then check the flow rates. I'm going to be placing an acute mask on my patient. This needs to be delivered at a rate of 6 to 8 litres per minute. It provides 60% oxygen. I will attach the tubing. So I'm turning it on to 8 litres per minute. open this firmly over my patient's mouth and nose, avoiding catching the ears. I ensure that this has got a firm grip so that no oxygen is leaked away. Once finished, keeping the oxygen on at this moment in time, you remove the mask and turn the oxygen off. You then need to bleed the leftover oxygen by turning through the flow rates until you no longer hear it. I'm going to be using the bag valve mask to ventilate my patient. So I need to ensure that the reservoir is inflating correctly with no signs of leakages. So I'm going to prepare my bag valve mask and reservoir and attach it to the oxygen bottle. We use these at a flow rate of 10 to 15 litres per minute, and I'm going to put it on 15 litres per minute to begin with in order to make sure that the reservoir inflates correctly.
This provides 100% oxygen.
I will use a head tilt chin lift and insert an OPA. If I did not insert an OPA, the tongue could roll back posteriorly, obstructing the airway, which would create snoring sounds. I need a good seal from nose to mouth, using a single user CE grip. I will ventilate my patient every 5 to 8 seconds, making sure there's no gastric inflation, which if there was, I could get my second user to apply cricage pressure if needed. I'm also assessing for chest rise. I can see the chest rising. This can also be used as a high concentration style mask, holding it there with no squeezing. I'll be checking my mask seal, making sure that there's no airway obstructions or there's no issues with obesity. I'd also be looking for their age, making sure that all their teeth are intact and that they have good neck mobility. I'd also check for stiffness and any snoring sounds. If my patient had significant facial hair, I would use a combine dressing and cut it, place it over the mouth, covering the hair, and then putting the bag mask over the top of the dressing to create a good seal. If I'm not using any oxygen, I would remove the reservoir. I'm now going to be demonstrating fracture management to my patient who has a suspected lower leg fracture. So I will gain their consent and I will gain a patient history using the mechanism of injury and the plus discs mnemonic to ascertain whether a fracture is likely or not to be present. So I will assess their pain on a scale of 0 to 10, 0 being no pain and 10 being the worst pain they've had. My patient states their pain is currently at an 8 out of 10. I will look for loss of movement, unnatural movement, swelling, deformity, irregularity, shortening, crepitus and shock. As they stated their pain is at an 8 out of 10, I will administer methoxyflurane as this is indicated for use in moderate to severe pain. They need to take 2 to 5 breaths on this to get it to start working. The contraindications are known renal impairment, family or personal history of malignant hypothermia, if they can't obey commands, and if they have received methoxyflurane within the last week. Adults can receive up to a 6 ml dose in 2 doses, and children receive up to a 3 ml dose in 1 dose. The side effects can be drowsiness, lightheadedness and nausea, but these are rare, only felt in a few patients. Methoxyflurane is effective pain relief and it will take the pain away. So I just need to do a drug check, checking the name of the drug, the expiry dates, checking the clarity, making sure it's all intact and that it's not been tampered with at all. I will then just get my bystander to come and do a verbal drug check just to make sure that what I've read is correct. So if you can just tell me the expiry date and the name of that.
Okay.
Now I've done my drug check, I can start to get the methoxyflurane ready. So I'll unscrew the ampule, pour it in here, That's 3 mils, and I'm only doing 3 mils at a time. My patient needs to hold this around their wrist, using their finger to cover the hole on the top. Cover their mouth over the whistle and take some deep breaths in and out, making sure they breathe out of the whistle to minimize the fumes in the environment. I can now check my limb baselines. So we'll compare this to the uninjured leg, looking at color, capillary refill time, which should be under 2 seconds, the warmth, if they have sensations, so if they can feel me touching along their feet, toes and their soles, if they can wiggle their toes in both feet. I need to check the pulse distal to the injury, in this case the pedal pulse. And we'll also need to check the SpO2 using a pulse oximeter. We're now going to prepare to splint. So we're going to very carefully and slowly lift up your leg, place a box splint with a towel already in it for support and comfort. We'll slide that in underneath your leg and immobilize it. Okay, so if you can gently lift up the leg for me. Going to slide this in, and if you can put it down. Okay, now if you can hold the splint up. I'm going to place 3 triangular bandages under the splint to make sure that the injury is immobilized above and below. Okay. With this last bandage, I will tie it around the base of the splint to create a stirrup-like support. I now need to check my limb baselines again, checking for colour, the capillary refill time, warmth, their sensations, their movement. Need to check their distal pulse and make sure it is still there, particularly in the splinted leg, and also check their SpO2. I also need to ask them their pain scale again, as the methoxyfluorine and the splinting should minimise their pain. I'm now going to demonstrate using the LifePak 15 monitor. To start with, we need to check the batteries. To do this, you press the button on each battery and make sure that they are fully charged. We need to turn the monitor on. We then need to put it into manual mode by pressing Energy Select, into manual mode, and yes. We're going to put this to 50 joules. And we're going to run a user test by pressing Options and scrolling down to User Test. The user test is now in progress. Whilst it's doing that, we can do a check of the machine to make sure that all the consumables are in there, and also checking that you've got in-date defib pads. We're now going to do a test charge to make sure that the defib is working. So I will attach my test load, and it's already selected onto 50 joules, and we'll press charge. It's charging up to 50 joules now, and then when that's done, you press the shock button to make sure that the energy has been delivered, which it has. To disarm a charge, you press charge and you push the speed dial to cancel it. It's now disarming, and it's disarmed the charge. To get back into AED mode, you click Analyze. I'm now going to connect my ECG cables to a simulator. And to change between the leads, we press the lead button, and you can scroll down to the leads that you desire. We're going to use 3 leads. To increase the QRS volume, you scroll up to the heart rate, press select, and you can increase the volume. This volume should be used when monitoring patients, so you have an audible clue of any heart rate changes. I'm now going to adjust the amplitude of the ECG size by pressing sides and scrolling down to the desired measure. It's now coming up bigger on the screen so it can be easier to see. To take a blood pressure, you use the NIBP button, which is a non-invasive blood pressure. To change the ECG paper, you need to pull up the flap, remove the paper, get your new roll, and gently but firmly pop that in. When the monitor first switches on, it defaults to the defib pads. In the left-hand pouch, you have your defib pads, 12-lead ECG, GTN spray, a razor and aspirin. In your right pouch, you have your ECG leads, your SpO2 pulse oximeter, your BP cuff and your end-tidal CO2 consumable. The end-tidal CO2 consumable is attached with the orange end into here, and you gently rotate it clockwise. If a lead comes off when monitoring, it will display on the screen with a dashed line. I'm now going to be demonstrating C-spine collar application to a patient. To determine whether a C-spine collar is to be applied, we use the Nexus rules. These rules are alert mental status, no intoxication, no neurological deficit, so no tingling in the fingers or the extremities, no painful distracting injuries, and no posterior midline C-spine tenderness. To ascertain whether this is present, we palpate the C-spine. So a collar is going to be applied in this case, and we get an offsider to come and hold the head to immobilise it in the sniffing position. This is for neutral and natural alignment. We measure for a C-spine collar. Put in your fingers at the base of the neck to where it meets with the jaw. We then measure on the collar, and this one is the correct adjustment. If it was not, we would adjust it using the clips. We slide it under the neck, ensuring that the jaw is firmly held in place with the collar touching the sternum. Once the collar has been applied, the offsider needs to keep holding the head until we can perform a full immobilisation. I'm now going to demonstrate controlled and uncontrolled hemorrhage and wound care, starting with controlled. So I'm wearing PPE of gloves and glasses. I have exposed the wound, and I will clean it with some saline. I will then saline some gauze and pack this into the wound. I will then saline a combine, fold this in half and put it over the wound. I'm using the smallest dressings possible to create maximum pressure. Then going to get my bandage, and while still applying pressure, tighten the bandage around the wound. Can also twist when I get over the wound to apply more pressure. I want to tighten each time I go over the wound. I'll then tuck that in and could secure it with a pin or tape if necessary. I then need to check if that has controlled the bleeding by making sure that no blood is leaking out. If it's not controlled the bleeding, I could use a second combined dressing with a bandage over the top of this one. I could elevate the arm, use indirect pressure, steri strips or a tourniquet. For a sucking chest wound, I would use an occlusive dressing of either cling film or defib pads, and for eviscerated abdominal wounds, I would use cling film over saline sloped dressings. If this wound had uncontrolled or catastrophic bleeding, I would use a combat applied tourniquet. I would apply it to the bone 10 centimetres proximal to the wound. It needs to be done up nice and tight. Then use the windlass to turn to tighten it even further. I need to write the time and the date on here very clearly. To make sure that that's worked, I can check for a pulse distal to the wound, in this case, a radial pulse. The patient will need analgesia if they're conscious, as a tourniquet is painful. I would also call for backup for IV access. If the bleeding has not stopped, I could use a second tourniquet immediately proximal to the first one. I don't remove the tourniquet, I keep it uncovered and transport to hospital. I'm now going to demonstrate being called to an unconscious patient. So I've checked for dangers. Dangers here is that it's just quite a confined space, so I've set my gear up in order to try and help with that. I'm also wearing gloves and safety glasses as my PPE, so it's now safe to enter. I'm going to check for response. Hello, hello, can you hear me? Whilst also checking for a radial pulse. There's no response to voice. Doing a trapezius squeeze. There's no response to painful stimulation, so I will come and check his airway. Performing a head tilt chin lift. There doesn't seem to be any obstructions in the airway, so I now will check for breathing. Look, listening and feeling for 10 seconds. Okay, there's no breathing. Can you please start compressions? AU21 calls control.
Control to AU21.
We have an R49 and require an R50.
Roger.
Okay, I'm just putting up the AED around you. Please continue compressions.
Analysing heart
Hanging
rhythm.
off the chest.
Do not touch the patient.
Okay, stand clear. If you just step back a little bit. Clear.
Shock advised. Charging. Stay clear of patient. Deliver shock
Okay,
now.
standing
Press
clear,
the orange
preparing to
button
shock.
now.
Clear, shock in.
Shock delivered. Pause.
Okay, resume CPR.
Start CPR.
Did anyone see what happened?
No.
Okay, and I'm turning my oxygen on to 15 litres per minute. If you can continue compressions, I'll tell you when I'm ready. Okay, I'm ready. If you count from 28 and stop at 30.
Twenty-eight, 29, 30.
1, 2, and I'm assessing for chest rise, and the chest is rising. We ventilate at a rate of 2 breaths for every 30 compressions.
28, 29, 30.
1, 2. That's really good compressions. That's a good depth, allowing for good recoil, so keep that up. I have suction here if needed. I don't need to use it yet as there's no airway obstructions, but
28,
it's here
29, 30.
if that changes. 1, 2. So I'm ensuring a good seal over the mouth and nose using a single user CE grip. We could also apply cricoid pressure if needed.
28, 29, 30.
1, 2, and I'm looking for chest rise. The chest is rising. Next time the AED is analysing, we'll swap. If you go behind me and I'll go in front of you.
Stop CPR.
Okay.
Press the orange button now.
Shocking, staying clear.
Shock delivered. Pause. Start CPR.
"28, 29, 30. And I can feel the chest rising. "28, 29, 30.
And
Chest is still rising. So we will continue doing this until backup arrives, and when they arrive we will take direction from them. To take a pulse we can use the radial artery, the brachial artery, the femoral artery, and we can also take a carotid or a pedal pulse. I'm going to be using the radial artery to take a radial pulse. So I need to place my fingers over the radial artery where I can feel the pulse. I'm going to time this for 30 seconds. Okay, so I've done that for 30 seconds and I got 45 beats during that time. So I times that by 2 to get a pulse of 90 beats per minute. This is within normal ranges, as normal ranges for an adult are 60 to 100 beats per minute. I only took that for 30 seconds. If I felt that the pulse was irregular during that time, I would take it for the full minute. I also need to state the strength of the pulse, so whether it was strong, bounding or weak, and in that instance it was strong. I'm now going to take a blood pressure from my patient. So to start with, we need to ensure that all restrictive clothing over the arm has been removed. I then need to locate the brachial artery and feel for the pulse. I then need to place my blood pressure cuff with the artery arrow lining up to just above where I felt that. And I can click my dial on here. I'm then going to feel the radial pulse and squeeze the bulb until I can no longer feel the pulse. I then give one more squeeze of the bulb, and that is my systolic marker. I will then be using my stethoscope and placing it over the brachial artery where I felt the pulse. We'll very slowly release the pressure in the blood pressure cuff. So the point at which I can hear the highest audible sound is a systolic blood pressure, and the point where this goes away, so I can no longer hear any sounds, is a diastolic blood pressure. In this instance, the blood pressure is 125/80. This is within normal ranges, as normotensive is considered to be a systolic blood pressure of below 140 and a diastolic of below 90. Someone is considered to be hypertensive if their systolic pressure is above 140 and their diastolic is above 90. I'm now going to take a respiration rate. So I'm going to watch my patient and see how many breaths they take and time it for 30 seconds. And if it's regular, I will times that by 2. If it's irregular, I will take it for the full minute. My patient has a respiration rate of 14.
Normal for an adult is 12 to 18 breaths per minute.
I now need to assess for the volume and clarity. To do this, I need to auscultate with my stethoscope. So I'm going to be placing this on the mid-axillary line and on the base of each lungs and listening to the inspiration and expiration. Okay, so if you can take some deep breaths in and out. Okay, so that all sounded nice and clear. Some things to watch out for would be an expiratory wheeze, which indicates bronchoconstriction, which could be due to asthma. Rails or crackles, which are caused by pulmonary edema. And stridor, which is an inspiratory high-pitched noise, which is due to constriction and narrowing of the upper airway, for example, during croup. I could also take a respiration rate whilst taking my patient's radial pulse. This way I'm doing 2 vital observations in one go, and also not worrying my patient that I'm watching them breathe.